The holidays have begun. Winter is here, and so are the respiratory viruses. Welcome to the Urgent Care Association Solution on Demand webinar brought to you by HealthTrackRx. Today we'll be discussing some interesting patient cases and the role of multiplex rapid PCR in optimizing clinical decision-making in the urgent care center during these winter months. Respiratory tract infections can be caused by viruses, bacteria, and they're more common during these winter months and can present with similar symptoms that can cause clinical confusion and make patients really difficult to diagnose and treat. I'm your moderator, Ben Favre. To work through these cases today, we're joined by two experts in molecular infectious disease diagnostics in the urgent care setting. First, we have Dr. Janie French, who is the medical science liaison at HealthTrackRx and a clinical microbiologist. Janie, how are you doing today? Happy holidays.
Hi, Ben. Happy holidays to you as well. I'm excited to be here. Respiratory infections can be caused, like you said, by viruses or bacterial pathogens, and sometimes both, or sometimes bacterial infections secondary to viral infections. And because symptoms of respiratory infections are frequently overlapping, teasing out what's happening with the patient can be challenging. But it's important to identify the cause of infection to make sure that patients get on the right treatment.
Thank you, Janie. And we also have Dr. Stephen Goldberg, who's an urgent care practitioner at University of Louisville Health, most importantly, and he's also has a very important job as Chief Medical Officer at HealthTrackRx. Dr. Goldberg, how are you?
Great to be with you and Janie today, Ben.
Thank you. Dr. Goldberg, as we jump into things, I'm interested to understand from a clinician's viewpoint, what do you focus on in dealing with the challenging patients that you see in the urgent care center this time of year?
Well, Ben, I'm excited to discuss these cases and cases that are occurring at this time. As an urgent care clinician, I found it helpful to apply principles of evidence-based practice, case by case by case, so that drives consistent operating by the clinician. That said, each case still has to be considered individually, and we'll show how that's so important on the cases we discuss today.
Fantastic. So let's jump into our first case. So Dr. G, our first patient here is an 88-year-old nursing home patient that presents with cough, runny nose, and nausea of 2-day duration. Recent facility transmission of COVID-19 and influenza virus. The patient has COPD and coronary atherosclerotic heart disease. No history of COVID infection. Flu illness history is unknown. No recent vaccinations, interestingly, and a temperature of 100 degrees with mild ill appearing, not short of breath. Lung exam has decreased breath rales and rhonchi. Laboratory COVID and influenza AB point of care antigen test is negative. So Dr. Goldberg, this is a complicated patient, a lot going on. Clearly you have a sense of urgency in taking care of this patient. What are you considering?
Ben, you're right. Complicated patient, a lot going on. The first thing I do is get my mindset right as I'm thinking through the information you just provided. When you engage patients above 85, and for that matter, somebody 65 and above with comorbidities, the extent of the illness they actually have might not be fully manifested in the signs and symptoms that they show in your clinic. Have to keep that in mind. We also want to consider the client's living setting, their medical history and exam findings, and any available diagnostic insights that's available in our clinic. So considering all of that to inform our medical decision-making, the care plan, and the treatment and follow-up plan.
Very good. So Dr. Goldberg, you have a great advantage today in that you get to phone a friend whenever you need. You have a clinical microbiologist and Dr. Janie French here to help us out. So
Awesome.
Janie, that makes it easy, right? We always wish we had one in our back pocket all the time. So Dr. French, how would you advise a practitioner such as Dr. Goldberg to think about the pathogens to consider and the diagnostic options for this patient?
Absolutely. Like Dr. Goldberg said, this is an elderly patient with comorbidities. Viral illness may be more severe in this patient, and there may also be additional concerns about development of pneumonia. But beyond that, you also mentioned that this patient resides in a nursing facility, and congregate living can mean that there's elevated transmission risk. So if this is a viral illness, we want to identify that because getting them on an appropriate antiviral treatment may mean that we can reduce transmission to other residents within the facility. That's something we want to be keeping in mind. Next, we want to be thinking about diagnostic techniques available. Many clinics have rapid antigen tests available for performing tests in the clinic. However, CDC recommendations state that these antigen tests for flu specifically less effective when used more than 4 days after illness onset, because at this point, influenza virus shedding decreases after this point in most people. However, this patient presented early during illness, so we're not so much concerned that the length of illness is going to impair our ability to detect infection by a rapid antigen. We want to also be thinking about what is viral circulation like within the community, as this is going to be really a major indicator of the accuracy of our rapid antigen tests. While antigen tests are effective for identifying viral illness during periods of high viral prevalence, periods of low virus circulation reduce their positive predictive value. So, for example, when influenza prevalence in the community is less than 2.5%, the rate of false positives is very high, even with a very specific test. So if an antigen test is positive during times of low influenza prevalence, like perhaps in the summer months, a PCR test should be used to confirm the diagnosis if clinical decision-making is going to be impacted by the test results. In this particular scenario, a negative antigen test might not necessarily be sensitive to completely rule out COVID or influenza infection if prevalence within their congregate living facility or within the community is overall low.
Excellent. Great insights, Janie. Dr. Goldberg, you have a wealth of knowledge there to help you in your clinical decision making. Walk us through what you're thinking in this patient and what your next steps are.
Absolutely, Ben. And as Dr. French described, thinking about the accuracy of testing, thinking about the congregate living, thinking about the different pathogens is super to have in your mind as you're walking in to evaluate the patient. So here's how I think through the case. The first, severity of illness. How sick is this patient? Now, this individual has medical comorbidities and exam findings that were described that could indicate pneumonia. The highest death rates for people with pneumonia are those above 70. Then I'm thinking about the intensity of care needs. So once I figure out what's going on, I need to assess if I can get them what they need in the congregate living setting where the patient resides. Then I ask myself, is this patient safe for outpatient treatment? I keep in mind different clinical algorithms. The IDSA has them, other groups have them, that suggest if certain features are present, person's more likely to do better with treatment in the inpatient setting. Now, in the history we got, there was no note of cough or sputum or dyspnea or pleuritic chest pain. And those are all features in the IDSA guideline that suggest this person might do better treated in the inpatient setting. So I think we're going to be okay with outpatient management. Then we want to think about medication regimen and if we're going to treat for bacterial infection. And in that case, we want to consider if the patient would be at risk for more difficult bugs like methicillin-resistant Staph aureus or Pseudomonas infection. And finally, risk to follow-up. We want to make sure we're going to be able to watch the progress of the patient's response to our intervention to confirm they're getting better.
Very good. Great insights. Thank you, Dr. Goldberg. Let's move to our first audience survey question. How do you use rapid antigen tests in your practice for respiratory testing? I use rapid antigen tests year-round. I use rapid antigen tests during respiratory season, and I never use rapid antigen tests. Wait a second here and let a few answers come in. While we're waiting for the answers to come in, Janie, quick question for you. Dr. Goldberg mentioned some of the multi-drug resistant pathogens like MRSA and Pseudomonas. I know one of your areas of expertise is polymicrobial or mixed infections. In a patient like this, what are your thoughts and concerns about those pathogens?
In general, secondary bacterial infections causing pneumonia are really going to be of concern after a viral infection. Given the length that this patient has been ill, it's probably not of major concern at this point to worry about bacterial infections. It's more likely that they're going to have a viral respiratory infection instead.
Excellent. Very good. So we have our results. Dr. Goldberg, preponderance of people are saying they use rapid antigen tests year-round. Any surprise to you there?
No, Ben, while data suggests many of our clinicians are making decisions without the opportunity of diagnostic insights at the point of care, it seems many of our listeners have point of care testing, and where I practice, we do as well. We're able to identify group A beta hemolytic strep, we'll call it strep A hereafter, influenza A and B, and COVID-19 when evaluating respiratory complaints.
Excellent. Very good. Janie, anything to add on this case before we move on?
I just would add that I don't think there's necessarily a singular right approach. We want to keep in mind the limitations of rapid antigen tests. These are going to be most effective during respiratory season for identifying a positive result. And in the summer months or outside of respiratory season, these tests are going to be more valuable for identifying negative results, as that's when the negative predictive value is going to be higher. So using that information to appropriately interpret the rapid antigen tests will improve outcomes overall.
Dr. Goldberg, one other quick question for you. JAMA recently reported a high rate of diagnostic errors for a patient very similar to this, patients with community-acquired pneumonia. Clearly, the current paradigm of no test, no culture or testing, and then using empiric therapy needs to be improved when you have that rate of diagnostic errors. What can PCR offer that may help improve diagnostic errors for a patient with pneumonia?
That study, a European study, large study, looked at both initial evaluation in the ER and time to treatment in the hospital, gave us some interesting insights. And it basically showed how PCR appropriately applied can get a diagnosis in a time-based manner and more likely treat someone more accurately because of that. And that overall should improve outcomes. So that can be very, very powerful.
Excellent. Great insights. Thank you. Let's move to our second case. Dr. French, here we have a 2-year-old male presents with ear pain, previously treated for otitis media just 5 days ago, has a history of recurrent ear infections, and received 3 doses, 2, 4, and 6 months of a 4-dose pneumococcal vaccine series. Did not receive the dose between 12 and 15 months. Clinical exam, a fever of 100 with bad pain, erythema and bulging of the tympanic membrane with loss of normal landmarks. So Dr. Goldberg, my little boy is hurting. Help him out, please.
We'll do our best, Ben. The child in our picture looks great. The story we're describing, not so. In those cases,
true.
The child is miserable. The parent is miserable because the child is miserable. Both want the discomfort to go away quickly. They want to get back to the routine. I think it's important when we start the evaluation to acknowledge those feelings, then take a deep breath and start thinking through your evaluation. Want to be able to do good decision making. In this note, we see erythema and bulging of the tympanic membrane, and that is consistent with acute otitis media. What's also relevant here is this child has a history of recurrent ear infections and was just treated for otitis media. So that sets up a certain profile that we need to consider, which will form our evaluation and treatment planning. Now, most otitis is caused by viruses, but we see this child missed a pneumococcal vaccination and had recurrent episodes. The child likely has received recurrent previous antibiotic treatments for those other ear infections. Now, pneumococcus is the leading cause of bacterial otitis media, and we see this child is not completely immunized. So I'm concerned that they're set up for a bacterial infection.
Got it. So Janie, recently treated, a missing vaccine dose, recurrent infection. From a pathogen and diagnostic perspective, walk us through what are options here to get an accurate diagnosis and treat this patient.
Let's start with some epidemiology and clinical considerations. So acute otitis media occurs most often secondary to viral infection, where the viral infection allows the bacteria in the nasopharynx to spread and flourish, causing those symptoms. Studies have actually looked at this relationship between otitis media and respiratory virus circulation and have found that there were significant association between peak activity of RSV, human metapneumovirus, and influenza A with office visits for acute otitis media. There's a chance that this is just viral, but it could also be viral leading to a bacterial infection. And the AAP does allow watchful waiting in a patient with uncomplicated symptoms that are non-severe. That would include cases like unilateral in young children under 2 years of age, or even bilateral cases in children over 2 years of age. But given that this case involves a patient that was just treated 5 days ago, this is likely a more complicated scenario, and you're going to be looking for a treatment option. What do we want to keep in mind from a microbiology perspective about treatments? It's recommended to include additional beta-lactamase coverage if the child has received amoxicillin within the past 30 days, because amoxicillin treatment prior and the failure of that treatment likely means that the bacteria present in the middle ear is potentially resistant in some ways to the amoxicillin. So you want to add that beta-lactamase coverage to overcome resistance and get that bacterial infection finally resolved. But when we're talking about otitis media, what diagnostic techniques are available? Many cases of otitis media are going to be treated clinically, diagnosed clinically, and then following treatment guidelines. However, in those situations where the child has failed 2 or maybe 3 antibiotics, oftentimes providers are going to be looking for additional tools to identify what's happening and make sure that the child gets an appropriate treatment. In these instances, a provider may opt to do a culture to look for bacterial pathogens present in that middle ear, or you could potentially opt to do a PCR or nucleic acid amplification test. The benefit for the PCR is going to be that you'll be able to test for both viral and bacterial pathogens. In this case, swab site is going to be really important. Nasopharyngeal swabs are often going to be easier to collect, especially in the outpatient space, where tympanocentesis is going to be the best option, but many providers in the outpatient space won't have the experience or the tools to perform this procedure. So nasopharyngeal swabs are an option here, and they're often going to be sensitive, but not necessarily extremely specific. So if a bacterial pathogen is detected in a nasopharyngeal swab, it may be what's contributing to that infection and those symptoms, but it may also just be representative of flora in the nose. We want to be mindful of that when deciding a swab site for these cases.
Excellent. Thank you, Janie. Great insights. Dr. Goldberg, clearly resistance is an issue, as you mentioned and Janie confirmed. How would you approach this test as far as getting my boy healthier and getting rid of that pain?
Well, Ben, Dr. French gave us a great overview of a range of considerations in thinking about otitis media. I don't think, unfortunately, this child has uncomplicated otitis media. I don't think they're a candidate for watchful waiting. I'm concerned that they need an antibiotic. So I get there because I'm referencing clinical guidelines like UpToDate, recalling the previous history. Most people with acute otitis media get better in 48 to 72 hours. This child didn't get better. He was brought back to the clinic, was re-examined, and unfortunately had findings consistent with acute otitis media. So that's unfortunate. I think we're on an antibiotic course. There's several regimens that could be appropriate for someone who's failed previous treatments. They could include high-dose extended-release amoxicillin clavulinate, ceftriaxone, levofloxacin. I try to start with the narrowest spectrum possible. And then finally, it sounds like we're at 3 episodes, maybe 4. So this child might be at the point where they need an ear, nose, and throat otolaryngology consultation.
Excellent. Great insights. Let's move to our next audience survey. When do you test for otitis media pathogens? After 2 failed antibiotics, 3 failed antibiotics, never. I send to a specialty consult. And while those answers come in, Janie, you mentioned some different swabbing techniques, nasopharyngeal swabs, and then the other test that you mentioned. Can you ever just swab the fluid in the ear, and do those give better results?
Typically, if you're going to be looking for middle ear fluid, it means performing tympanocentesis. And many children are going to be hesitant about that. So nasopharyngeal swabs are going to be much more accessible to many providers and less frightening to the patients as well. And one possible way to obtain information on the middle ear pathogens and their antimicrobial susceptibility is to do that nasopharyngeal swab, because almost all middle ear pathogens derive from pathogens that colonize the nasopharynx. But the reverse is not necessarily true. So not all nasopharyngeal pathogens are going to be entering the ear to cause that case of otitis media. If a nasopharyngeal swab is negative for specific bacteria, that organism is likely not the pathogen causing the otitis media, and this information can really help guide antibiotic selection for these complex cases.
Excellent. Thank you, Janie. Dr. Goldberg, Janie mentioned watchful waiting, and you mentioned it as well, saying that this patient, you probably wouldn't want to do that. The other end of the spectrum is, okay, I'm going to just send this patient off to an ENT person. What are some tips on when you would watchful wait versus when you just send that person out to consult and handle this patient who may fit somewhere in between? What are your thoughts on when you use those different strategies?
Well, Ben, these cases are not cut and dry, and that's why we chose them. And hopefully folks are thinking through what they do in the clinic and how they sort through these problems. We saw this child had a complicated history. This was not a first singular episode of acute otitis media. Watchful waiting, according to the American Academy of Pediatrics, is appropriate for patients if they're 1 to 12 years old with clinical diagnosis of acute otitis media who've not had otitis media-related complications within 6 months, don't have tympanostomy tubes, have no other infections events around the index diagnosis of acute otitis media. So when we hear that guideline for watchful waiting and we look at this child, they don't match up. Given that this child was just recently treated and has a history of recurrent infections, I don't think they meet the criteria for watchful waiting.
Very good. Thank you. Let's move to our next patient. So this patient is a 56-year-old that presents with cough, sore throat, fatigue, and a runny nose. Symptoms 1 day prior, requesting antibiotics. The patient history has type 1 diabetes, prior history of sinus infections, and did not receive a COVID vaccine. High fever, 102, and laboratory point of care test was negative. So Dr. Goldberg, another sick person walking into the clinic, help us make sense of what to do with this patient.
It is a busy office hours, isn't it, Ben?
Yeah, for sure.
A few considerations. Having type 1 diabetes is an important consideration. It's not going to change my approach to this patient unless we're having observations that their diabetes are not in control. They've got diabetic ketoacidosis, they're dehydrated or other. There's not that information in the history to suggest that. This patient gives a complaint of a sore throat but has a normal oral pharyngeal exam. So that really doesn't support group A strep. And we'll show later that the clinical pictures of several of these illnesses look very, very similar. So I'm thinking viral versus bacterial. The note that point of care testing was negative is noteworthy. So it's inferred by that the patient was treated for both COVID-19 and group A strep, both of which could cause the symptoms described, but I'm leaning to the possibility of COVID-19 because the oral pharyngeal exam was normal. And it's suggested because the patient did not receive a recent COVID vaccination. Unfortunately, COVID-19 in the point of care setting testing can have a false negative rate. So I'm processing all that as we're thinking through what to do with this patient.
Very good. Thank you. Janie, what makes this case challenging from a microbiology diagnostic perspective?
Absolutely. There are things that we're going to want to keep in mind. So age is the strongest risk factor for severe COVID-19 infection. This patient is 56 years old, and while we don't classically consider that to be of older age or senior, actually age over 50 is one of the risk factors for severe infection, and that risk increases substantially for patients over 65. Compared with ages 18 to 29 years old, the risk of death is actually 25 times higher in those patients 50 to 64 years old. And while this patient is not a long-term care facility resident, these residents are at increased risk. So we want to be keeping in mind, what are their living conditions like? Because if they are in a long-term care facility, these residents, although only 1% or less of the US population, actually have accounted for 35% of all COVID deaths. So we want to understand what sort of conditions they're living in. Is long-term care a risk factor for them? Fortunately, in this case, it doesn't seem to be. We also want to be thinking about other risk factors, like Dr. Goldberg said, diabetes, obesity, chronic lung diseases, chronic liver diseases, and heart conditions are all risk factors for severe COVID infection. We also want to be thinking about COVID-19 circulation patterns for reasons that we talked about in our first case. Rapid antigen tests are going to have a stronger positive predictive value when circulation in the community is high. And in the US, peak circulation of COVID-19 has, in the past few years, occurred primarily in mid to late July up through August, and then a second peak annually sometime in the December to January weeks. So while these patterns may change as COVID continues to settle into a more regular pattern, this is what we've primarily seen. So it's likely that during these periods of time, the rapid antigen test for COVID will have better positive predictive values. And we want to keep that in mind when we consider our diagnostic techniques available, because rapid antigen tests are accessible. They're going to get patients answers quickly. A PCR test or other nucleic acid amplification test is often going to offer better sensitivity and specificity than a rapid antigen test. So PCR with rapid results is particularly valuable for infections such as influenza and COVID-19, where diagnosis of infection early, within 2 days specifically for flu, means that antiviral treatment is going to be most effective if clinically indicated for that patient.
Excellent. Thank you, Janie. Walk us through some of the clinical confusion that can happen with these patients, please.
Absolutely. When we opened this webinar today, I mentioned that, there's a lot of symptom overlap between common respiratory infections. And sometimes it may seem that it's possible to clinically differentiate common respiratory infections like COVID and influenza, but as you'll see in this table, many of the symptoms overlap between these common respiratory viruses. Really, the only unique symptom to COVID is going to be that loss of taste or smell, which is fairly common during COVID infection, but not as often seen in influenza. In the absence of this symptom, though, you're not necessarily going to be able to differentiate between whether a patient has influenza virus infection or COVID-19. So diagnostic tests are going to be really valuable there.
Excellent. Dr. Goldberg, you have that clinical confusion between flu and COVID here. You also have that opportunity to either treat or not treat because this patient is early in the symptoms. Walk us through how you're going to assess and what you're going to do for this patient who wants that antibiotic.
Then, if we're confident that we're not going to lose this patient to follow-up, if we're confident that they're going to be able to get excellent follow-up care in a congregate living setting, if we're confident that that setting is not going to put them at higher risk, and their chronic condition is stable enough that it's not a separate factor, then what I think we've got is a good setup for outpatient care. And one other factor is that the patient came to us within a day of the onset of symptoms. So what that tells me is if I'm thinking about an anti-infective, either for COVID or strep or other, and the patient's stable, I can wait 24 hours to get that definitive result to then engage them and get that treatment underway because I'm seeing them early. Other clinicians might want to start something empirically, but that would be what I would be inclined to do. I'm particularly concerned because of the normal oral pharyngeal exam for COVID-19 in this patient. And also there was the note of no recent vaccination because as Dr. French described, this patient is at higher risk for a bad COVID event, and they're also at higher risk for long COVID sequela. For those reasons, and yet confidence that we can wait till a next morning result, I would get definitive testing and engage them on follow-up. I think we'd be covered that way.
Excellent. Very good. Great insights. Thank you both. Let's get to our next audience survey question. Would you consider next day PCR testing for this patient? And while we're waiting for answers to come in, Dr. French, I heard on the radio yesterday that where I live in the New Orleans area of Louisiana is having a 10% positivity for flu, and that's higher than any place in the country. Knowing that PCR is the standard of diagnosis for respiratory viral infections, and some of the stuff you mentioned earlier with the importance of the incidence rate in your area, when would you determine, okay, I want to do that PCR, or there's a lot of flu or COVID or whatever it is circulating the area? When do you make that decision? Or is it so hard, as you mentioned with the clinical confusion, that you should test because you have that opportunity to treat for these patients?
Time of year is going to be important because it may allow for preliminary diagnosis. If the patient presents in the summer months with severe symptoms, it's much more likely to be COVID than it is to be influenza, because that's when we see a COVID peak, but we don't see a corresponding influenza peak. In the winter, it really could be anyone's guess because there's often overlap in circulation of influenza virus, RSV, and COVID-19. These all circulate at similar times of the year. So in that case, testing may be the only way to differentiate. But it's always helpful to stay up to date on what's circulating in your communities using publicly available resources. So that's a good place to start. And then testing is often helpful to diagnose officially.
Excellent. Dr. Goldberg, this patient came in wanting antibiotics. I know that's always a challenging scenario, right? They say they want antibiotics, but really they want treatment. They want to feel better. They want to get healthier faster. How do the current antivirals come into play in a patient like that, given that the patient is early in their course of therapy? And when do you make that decision to say, okay, yeah, we'll treat with an antiviral? And how do you deal with that patient who's insisting on an antibiotic from a clinician's perspective? Because I know that can be challenging and puts pressure on you.
And we're discussing these cases because they're complicated. And clinicians could have the exact same profile of a client and take slightly different approaches. I shared that for this case, I am most concerned about COVID-19. I feel the patient is likely a candidate for antiviral therapy, and yet I feel I can wait until next morning, given the profile, before I would institute therapy, waiting for that definitive diagnosis. Others might take different approaches. They might want to start the antiviral immediately. They might want to, frankly, start a short course of antibiotic immediately. People could do different things, but it's not easy. It depends on the setting, expectations, clinical practice style, but I've shared what my approach would be.
Excellent. Let's move on to our next case. Here we have a 10-year-old with a sore throat and swollen tonsils of 1-day duration. Patient history is unremarkable. Fever of 102, you have tonsillar exudate, and another case with a negative point of care test. Dr. Goldberg, my little man here has a sore throat. He was up all night, doesn't feel good. Help us out.
The good thing about growing up is you forget what it's like to have swollen tonsils and exudate. It is miserable.
Yeah.
And it's such a common occurrence in the urgent care clinic. Just one point I'll make about tonsillar exudate. Tonsillar exudate doesn't equal group A strep. It's an inflammatory response. Yes, it can be associated with a strep throat, but it also could be associated with mononucleosis and viral pharyngitis. And yes, the appearance of that exudate can differ, but it's not always pathognomonic. But throat swelling, enlarged tonsils, exudate, just absolutely unpleasant. Add on top of that a fever of 102. What I'm considering for this young client is what is the cause of that oropharyngeal discomfort, oropharyngeal swelling, and do I need additional diagnostic testing now, or do I do additional for the morning and then guide treatment based on that? What we see here is that the point of care testing was negative.
Thank you. And I'm telling you, this is the exact case my daughter had just this week. So I know exactly how much pain you're talking about. Janie, when this young gentleman or my daughter comes into the clinic with the sore throat, speed matters, right? They're hurting just like the young gentleman with the ear infection. What are the diagnostic options and what pathogens do we need to suspect?
With group A strep and strep throat, what we are trying to prevent is rheumatic fever. Rheumatic fever is most common in children over 3 years of age, but especially in those 5 to 15 years old. This patient's going to fit right into that category that is going to be most at risk. And we have a few different diagnostic techniques available to us because it's going to be challenging to distinguish viral and bacterial infections clinically. They may have very similar characteristics and testing is often recommended. So what options present to you? Many clinics will utilize rapid antigen tests for group A strep, as this is going to be a quick tool. And unlike many of the viral rapid antigen tests, group A strep tests tend to have better sensitivity and specificity than viral tests because circulation of group A strep is pretty consistent throughout the year. So the positive and negative predictive values don't change as widely as the seasonality changes. But in these cases where you get a negative rapid antigen test, it's often recommended for children to do additional send-out testing. And in those cases, you'll primarily utilize one of two options, either a throat culture, which is specifically going to look for Streptococcus species, or PCR. And this is going to allow you to definitively identify whether there's also maybe a respiratory virus associated with that. And, that identification, if it is viral pharyngitis, can often give the patient peace of mind of why an antibiotic may not be indicated. Different options there with different advantages.
And Ben, what I would add, based on this child's profile, can we try to use evidence-based practice? We try to use clinical rules. I think a Centaur score is helpful to consider decision-making. You have to consider elements such as the AIDS, exudates on the tonsils. Do they have swollen cervical lymph nodes? Is there a high fever? This child directionally would be leaning to a higher Centaur score. So the negative point of care testing is not consistent with that. Frankly, it's a bit confounding. And yes, the Centaur score can be variable. So I'm very concerned about group A strep in this child, even though the point of care testing was negative.
What y'all are saying is really resonating here. A comment that just came in, tonsillar exudate does not equal group A strep. You're preaching to the choir here, Janie and Dr. Goldberg. Well done. So Dr. Goldberg, in this patient, what's your treatment plan and how are we going to move forward?
Again, people will differ. Some would make a therapy decision based on the information we have here, and they wouldn't be wrong. My preference is to try to get a definitive diagnosis that I have high confidence in. I feel I can do that in this case because we're seeing the child within day one of symptoms. While I'm concerned about group A strep, as Dr. French said, what I'm trying to prevent is a valve infection or post-streptococcal glomerular nephritis. If I get that treatment going within 3 days, I'm going to be okay. This child's in within 1 day of symptoms. So this child's not toxic appearing. Guardian got him in, or parent, within 1 day after symptoms onset. So the inference is that they've got tight care of their children. I have confidence they won't be lost to follow-up. So given all of the above, I'll wait for a next morning definitive result before starting the therapy.
Thank you, Dr. Goldberg. With that, let's move to our next audience survey question. For pharyngitis, do you perform rapid antigen tests or skip straight to more sensitive culture/PCR? I always use rapid antigen tests before deciding to send out. I skip the rapid antigen test due to the lower sensitivity. I make decisions on antigen test results only. And while we wait to get some answers back, Dr. Goldberg, if this patient had presented on day 3 of symptoms, how would that change your thought process?
Again, going back, trying to drive evidence-based practice, the clinical exam, physical exam center score looked consistent with group A strep. The point of care testing was negative. I have to make a choice. I'm going to go with my clinical exam finding. 3 days, I'm concerned about endocarditis, post-streptococcal glomerular nephritis. I would have started the antibiotic in that case. Still gone and gotten the definitive testing, but would have started the therapy.
And Janie, we have an audience question here. What's the clinical benefit of including strep pneumoniae, MCAT, and H flu on a pharyngitis panel?
We see that these are very common respiratory bacteria, some of them associated with sore throat. Identifying the cause of the patient's symptom is always going to help the patient understand what's going on with themselves. Interpreting these respiratory bacteria is really going to be important in the context of what else is detected in that patient, because they may just be normal flora. So there are other respiratory viruses detected or group A strep in a pharyngitis patient. It's more likely that those are associated with the patient's symptoms. But there are some cases where maybe strep pneumo or MCAT might be associated with sore throat. Interpretation and context is really going to be important for them.
Janie, in those scenarios, the interpretation, would you base that based on the level that you're seeing in that patient, or can those be at a pathogenic level and still be colonizers?
So we do see that some bacteria like strep pneumo can be present even at high levels in the nasopharynx of children especially, but microbial load is going to be something that you'll want to keep in mind. As the higher the microbial load, the more likely a bacteria is associated with pathogenic outcomes in, the patient's symptoms. But most important is going to be, is the pathogen almost always pathogenic? Is it sometimes normal flora? That'll be the first step to interpreting reports.
Excellent. Thank you very much. Well, that's all of our cases today. A few wrap-up points. Janie, why don't you walk us through your thoughts on the wrap-up points and read them out to us real quick.
We've mentioned this a few times, but the negative predictive value and the positive predictive value of rapid antigen tests is going to be dependent on community prevalence. Using resources that are publicly available, such as virus circulation patterns published by the CDC. Additionally, HealthTrackRx does publish positivity reports on their website available to the public. These can be a great starting point for understanding what's circulating right now in the community. And rapid diagnostics in general are going to be valuable in reducing patient anxiety, improving patient outcomes, and preventing the overuse of anti-infectives. As we know that antimicrobial resistance is of increasing concern globally, so we want to be good antibiotic stewards. Last but not least, the rapid clinically actionable PCR can be a technique that allows testing for multiple types of pathogens from a single sample. So in situations or cases like the pharyngitis patient that we just talked about, being able to test for both group A strep and respiratory viruses is not only a tool for identifying streptococcal pharyngitis that needs antibiotic treatment, but it's also a tool for identifying viruses so the patient can understand that an antibiotic might not change their outcome. These are really just different helpful points to keep in mind as you go through respiratory season.
Very good. Dr. Goldberg, one of the takeaways that kind of comes through in these cases today is the importance of speed and the ability to get accurate diagnosis in these patients and be able to make that don't treat decision as soon as possible so they can get healthier faster. What are kind of the things you look at from a clinician standpoint on when do you say, okay, I want to do that rapid PCR because I can now get answers back the next morning? When do you pull that trigger and what makes you comfortable? And when do you say, hey, I'm going to use some diagnostic stewardship here and not do a test versus do the test?
Yeah, Ben, 3 considerations. So in someone that's elderly, they're not going to show the signs and symptoms that necessarily affect how ill they are. So I want to get that diagnosis right, and I want to get it fast. First case. The second would be in someone who I am concerned that I have to start a therapy to impact a sequela, long COVID, bad COVID, group A strep, seeding a valve, or a kidney. I want to get that right, and I want to get it done timely. Now, our cases, folks presented within a day, that was an opportunity. But if they were presenting day 3, day 4, the clock is really ticking quickly. And then finally, what I'll add is you really want to do evidence-based practice, have a method that you're using to evaluate these cases, but then look at each individual scenario and points such as where people are living. Are they going to be lost to follow-up? Are any of their health conditions out of control? And then the epidemiologic considerations that Dr. French highlighted are all important elements for decision-making.
Excellent. Janie, we do have one question that came in here. Is there anything that you have seen nationally or any local areas with any pathogens that would be of benefit to the audience?
Definitely. I know in the past few months there has been major concern about Mycoplasma pneumoniae. That's not a pathogen that we really discussed in depth today, but it's been of concern because it's been circulating at high levels this year, and we don't traditionally see much, if any, of that pathogen. So nationally, we've seen that positivity rate has been as high as 7%. On a state level, in some cases, it's been over 13% positivity in some individual states. So it's a bacteria that's really important to consider if you have a patient presenting with walking pneumonia-like symptoms. Additionally, we have started to see influenza virus circulation creep up in the past several weeks, but it seems to be displaying a different geographical pattern. Typically, we see influenza start in the southeast, particularly in Florida, and then spread north and west. However, this year, we've seen that influenza is really also starting more heavily on the west coast and seems to be spreading east. We'll continue to track that as influenza virus positivity increases because, like we've mentioned, it's important for understanding the likelihood of influenza infections in your own practices.
Excellent. Great insights, Janie. Really appreciate that. Dr. Goldberg, one quick question for you. You mentioned a study earlier that with community-acquired pneumonia and using PCR, or the guidelines suggest that you shouldn't do culture and you should just treat empirically. But the guidelines always don't move as fast as the science. And we're seeing studies such as that one and other points of data that are showing that by getting a diagnosis earlier, and like the study you mentioned pointed out, that you can get better antibiotic prescribing. How would you use PCR in those scenarios where speed really does matter and the gap in treating patients is there as far as the outcomes that we're getting with the current paradigm of treatment?
You and I have discussed there's a growing body of evidence about how PCR with next morning results can impact clinical decision-making favorably. And we're seeing that across a number of different syndromes, whether it's oropharyngeal, respiratory, or GYN. So it's good to have another tool in your box so that when people come in with a complaint, they're not feeling well, that you're able to offer them testing that gives them a definitive diagnosis and definitive therapy. So that's good. There's ongoing research work in a number of different syndromes. And I know we and other entities such as IDSA are continuing to collaborate to evaluate alternatives to just culture or alternatives to empiric decision making. The former because we need to find things that can get answers faster. And the latter, having good data to inform your decision making, environment, genotypic resistance, etc., can really help with your decision making. A little bit more than just using empiric decision making.
Excellent. Great comments. About finishes us up. Janie, any closing remarks?
Understanding what's in your communities and using appropriate diagnostics are going to mean the best care for patients. And antimicrobial stewardship is going to be an important consideration when patients are requesting antibiotics for respiratory infections. So I think it all comes together to inform how we care for patients.
Excellent. Thank you, Janie. Really appreciate all your insights today. Dr. Goldberg, anything to finish up with?
Evidence-based practice is a great way to stay anchored, do safe care and care that patients will appreciate. Yet you have to consider each and every patient. And yet for our case today, before we go to our rounds this afternoon, it's great to have Dr. French here, an epidemiologist, to give you that larger view that informs how you think about your care in the clinic. We really benefit from that today.
Thank you both. Thank you to everybody in the audience for joining us for this Urgent Care Association Solutions on Demand webinar brought to you by HealthTrackRx.